And this is the next episode of the No Damns Given podcast, brought to you today by The Rocket. Tim and Jim were on a couple of weeks ago, and we're doing it a little different tonight, mainly because of our crazy schedules. So it's a Wednesday night. We usually do it on Fridays. And I have Dr. John Abell here with us this evening. And thank you for being here, Dr. Abell.
Yeah, welcome, Doctor.
Thank you for having me.
Yeah, awesome. And so in the past couple of years, you've changed your practice. And what exactly have you done, and why have you done it?
So the answer actually goes back.
Speak in that mic, everybody.
The answer actually goes back around 12 or 13 years ago when I was practicing in Peachtree City, and then I moved to Albany. A patient of mine had given me a book called The Life Extension Revolution. I read the book when I finally picked it up and went through it in about 3 days, and I said, this sounds like some amazing stuff. And within the next week had booked to go to the annual American Academy of Anti-Aging Medicine, their annual conference. Spent 4 days there, and it really pretty much changed my life. At that time, they had a new fellowship program for board certification anti-aging medicine, and I signed up for it on spot and went through, and I was in their first group of graduating anti-aging doctors. And after that, went on, kept going through the process, kept learning, and learned of the Institute for Functional Medicine. And I started that program in 2010, and went through that and was one of the first 500 certified functional medicine doctors in the country. And so, you know, when I saw this, I said, this just makes so much sense. What I'm doing now compared to what I can do for patients in medicine, it just completely changed my whole outlook.
By the way, these wings are really good.
Rocket fuel.
And so I continued to be in primary care, really wanting to get out of primary care, but not really being able to do that financially until a couple of years ago when I finally decided to close primary care and focus all of my outpatient activity on functional medicine.
Okay, so explain to our listeners what's the difference between what a traditional medical model primary care physician might do and what a non-traditional functional medicine or functional medicine physician would do. Do they overlap? Is it completely different? What's the thought process?
So there is always a need for traditional medicine in acute care, but in chronic care illness,
so what would acute care? What's an acute care problem? Like an earache?
An earache. An acute cholecystitis.
Acute appendectomy.
Exactly.
A broken leg.
Exactly.
Yeah.
But many of the chronic illnesses, which are quite frankly what is weighing down the whole system, and each and every one of these in and of itself are predicted to be able to break Medicare by somewhere maybe 2025. Alzheimer's disease, diabetes, all of these things, all the complications of these illnesses can potentially break the system. But we know that, we know in kind of the functional medicine model, what we think about is the tree and the roots. Mm-hmm. All right? And if you got a tree, you got this branch going out here, and that's your lungs. You got another branch going out, that's your heart. You got another branch going out, that's an endocrine dysfunction or thyroid dysfunction. And so each different limb is treated in an isolated manner, whereas in functional medicine, what you do is you go down to the roots. And we say there are a problem in the roots, in the system that feeds the tree, in that we get imbalances that cause disease. And if we go back and fix the soil, fix the root system, then we can potentially reverse many of these chronic illnesses, as well as prevent many of these chronic illnesses. So that, in a nutshell, is
If you get to the root of the problem.
get to the root of a
Pun
problem,
intended.
address to the root of the problem. The body has its own innate ability to heal if you give it what it needs.
So just to rephrase a little bit, the way I understand it, and really the way I was taught. So medicine really is based on a model that came out of one of our greatest inventions, which is antibiotics. And antibiotics and acute interventions from the surgical standpoint. And we brought up two of them: cholecystitis, or removal of the gallbladder, which would be the surgical treatment for acute cholecystitis, and appendectomy. It's one of the reasons I love surgery. Was because you could fix a problem, the patient got better, and then you moved on. You actually cured something. Whereas, and then what's happened is we've taken that same medical model, or that same idea, meaning there's a problem, let's find a pill to cure it, and then let's move on, and that is how we've been taught to deal or do things. We've done that with, say, hypertension. Hypertension is actually a symptom of a problem. It's not an actual problem. But we can take a medicine and we can reduce your blood pressure. And yes, there's a good outcome for that if you look at large populations. But are you actually changing the course of the disease? Is that it? Am I thinking about those things correctly, or are we?
No, I think absolutely.
Yeah.
And the example that you brought up, hypertension, there was a wonderful lecture out of a guy from the University of Adelaide. He went through, and he went through. This was 10 years ago, and I keep trying to go back and find that. I actually wrote it all down, but ultimately, hypertension, as you speak of, is a disease of the angiotensin-renin system. And this has been, the problem with this is because of everything we've done over the last 500 years in our society. There was no hypertension in years past. There is no hypertension in the indigenous societies. The average blood pressure in the Aborigines is 90/60. And so what we've done is we've taken, with all of the things that we've changed in our environment, in everything that we've done, that stimulates abnormalities. And basically hypertension, as Mark Houston would talk about it, boils down to at the endothelial level to one of three things: inflammation, oxidative stress, autoimmunity. All three of those things have been introduced into the human body by what we've kind of created, starting probably around the Industrial Revolution.
So inflammation. So let's talk a little bit about that. There's a few years ago, it was mentioned only in the area in which I am, which I'm a vascular surgeon. I'm double boarded in vascular and general surgery, and it was things of this nature were mentioned only to be derided. And so inflammatory gut or leaky gut or those symptoms were a problem that were only seen in severe celiac disease, which was only seen in a very minor population. But now that particular problem has a lot of data that supports it. And I think one of the things that that I like about this is that it's data driven. So inflammation and inflammatory or leaky gut syndrome is a big part of that process, and it's really a starting point for a lot of these inflammatory disease states. Can you go through and explain in sort of layman's terms how part of your gut, how part of the change in what we've eaten over the past 1,000 years, how does that affect like my high blood pressure, or the fact that I got I've now got coronary disease, or even GERD, gastroesophageal reflux disease. All of those things relate back to, right or wrong?
Absolutely.
It's a lot of fried foods.
Silent Bob.
And with respect to, your statement about that was kind of derided. My buddy up in Nashville, he was my roommate at Emory. He is my son's godfather, and he's one of the chief cardiologists at St. Thomas Heart Group. Was one of the most respected groups up in Nashville. He told me the last time I went to see him, his first cardiology boards was all about plumbing.
Mm-hmm.
It's a plumbing problem.
Right.
And his follow-up cardiology boards focused on it's an inflammatory problem.
Mm.
Mark Houston would say that autoimmune disease is probably going to be the number one cause of coronary disease in the United States now. So to kind of go into where you were speaking of what does the gut have to do with this? And Mark Houston will talk about this as well. And Mark Houston, number one vascular doctor in the world, says before I could become a good vascular doctor, I had to become a good gut doctor, because the concept of leaky gut, or actually the proper terminology is intestinal permeability, has been out there and has been developed for years. But what happens as you develop, and this is shown in many long distance runners. So you've heard of the long distance runner, the marathoner that drops over dead.
Mm-hmm.
Why do they do that?
Leaky
They
gut.
do that because as they're running, what their body does, they shunt the blood supply to the muscles, and they take it away from the intestine. And I was in a worldwide conference on this several years ago. What they do is they shunt blood away from the small intestine, at which time you get intestinal...
Let me break in there. So this is a well-known phenomena that long-distance runners get, and the reason I know is because I've had it. So when I was training for the marathon, 5-6 years ago, I would when I got up into the 18 to 20 mile range, sometimes afterwards I would get a terrible fever. It felt almost like a flu-like illness once I was done, and I'd have to go to bed, and I really felt awful. Well, after doing some research, you get antimicrobial translocation in the bowel from ischemia.
Absolutely.
From exactly what you're talking about.
Bingo. You get endotoxins. Endotoxins are the cell walls of bacteria that, because of the intestinal permeability, because of the separation of those microvilli, and it's interesting, our small intestine, if you lay it all out, is the size of 3 tennis courts. So you've got 3 tennis courts out there. That's our barrier against everything that comes in through our body, about 2 billion pounds, or 2 million or 2 billion pounds of food in your lifetime. And that also protects against these bacteria coming through. But what happens is you get separation, and endotoxins, or bacterial cell walls, come into the bloodstream. Bingo. You get endotoxemia. Mm-hmm. And then, what's more cool about that, the body's first line of defense against these endotoxins is that our cholesterol goes in and gobbles it up. And what that does, it transforms a healthy cholesterol particle, a large, fluffy cholesterol particle, into a small, dense cholesterol particle. And the way you can kind of picture this, picture a bowl of popcorn popped and a bowl of popcorn unpopped. Which one is more likely to migrate through the endothelium or the vascular wall?
Mm-hmm.
It's going to be the unpopped.
Mm-hmm.
And that's what the cholesterol does. It changes them into a small, dense that's able to deposit under the endothelium.
Is that your HDLs?
That's your LDL. That's your
Your
small, dense LDL.
Well,
So
I'm only double boarded in Sholey and Wright Charles, so I'm not exactly sure.
Yeah,
So
that's okay.
before we go any farther, tell us what you're drinking and why you like it.
You know, I'm drinking some Skywater Golden Ale, Pretoria Fields. It's just an amazing blend that you guys have come up with, and this is the one that I go to whenever I come.
Oh, awesome. I guess we should also say that tonight's podcast is brought to you by the Georgia Center Med Spa, for which we have the fabulous Nikki here tonight. Nikki, what do you do?
I inject the faces, make them pretty.
Come on. Yeah, speak into the mic.
Botox, Juvederm.
Get those pretty lips up
Thank you.
there.
All right. I inject Botox, Juvederm, make everybody pretty.
Yeah, awesome.
You know.
And you're a registered nurse,
I'm a registered nurse.
and you also help Dr. Morgan.
I do.
And I've talked about myself in the third person.
Yes, I do. I help.
Perfect.
I help him in the mornings in surgery at Albany Vascular.
Yeah,
So I do all kind of fun things.
very good. Back on topic. So then when we look at, this is, if I understand it right, the idea is that the chronic inflammation in the gut is causing this translocation of bacteria or food, and then it's revving up the immune system. And then what does revving up the immune system have to do with my heart disease or my vascular disease or my hypertension?
So it comes as different pictures, but the translocation of the endotoxins changes the large fluffy LDL, which is the good cholesterol. Now, we all need cholesterol. So cholesterol is an absolutely essential part of cell membranes. Cholesterol is a good thing. Right. Cholesterol is not a bad thing. But when cholesterol metabolism goes...
So let's talk, hold on, I do want to harp on that point just a little bit. So there's actually an article in, I think this is the New York Times, and in which they describe how science changed and how it was changed for the worse because of some unethical scientists. Are you familiar with that article?
Not that particular article, but I'm aware of the concept that you're talking about.
Yeah, so describe that a little bit, because I think that's really important for people to know, because it's a pretty well established fact now that the recommended daily allowance for cholesterol has been changed. It's not that we're not even telling people not to. It's not a thing anymore. And so most physicians don't understand it. Most physicians don't know it.
Most cardiologists don't understand it. Yeah.
And so it's and it's just because it's hard to keep up. I get it. It's hard to keep up. But this is a real thing. And it was a subversion of the system in which sugar companies, and it's well described in this article, how the sugar companies actually paid for falsification of research, and then a huge body of literature was built on a false premise.
Absolutely. So if you go back in time, and talk about that, when all the USDA and all the guidelines for food, if that's when they started recommending low-fat diets, which by default are what?
High in sugar.
High carbohydrate diets. And if you track coronary disease, then what you're going to see is that when that statement came out, coronary disease started to shoot up. By default, a low-fat diet is a high carbohydrate diet. It is carbohydrates that are a main culprit in coronary disease. And, a good fat diet with proper fats, not trans fats, not, you want monounsaturated fats. You don't want the saturated fats. That's the issue. And so there's no question. That's been documented in the literature that we talk about all the time.
This is like the Dateline of podcasts.
Because we just broke some
We
news.
just broke some news.
So on the chronic disease spectrum, I think this is one of the more frustrating things that I have to deal with. Is that we've got everything from what you're doing, which is anti-aging medicine, and then taking cases that are just really difficult cases. The common thing that I see is somebody who's on the opposite end of the anti-aging spectrum, meaning they're at the end of their chronic disease state.
They're already aged.
They have aged to the point where they're in risk of death. So how do we? So we apply, and and it's difficult, but we've started to try to apply these things in our practice. There's such a pushback, though. It is difficult, and you and I have talked about it before. It is difficult to get people to understand their own culpability of what they should be, of what they could have done or what they have done in their body. So, what are some of the common things that you see in everyday practice, and how, and especially in the change in practice and what you've experienced on how you've gone from your stated primary care, internal medicine, to now more functional medicine? What things do you deal with on a daily basis?
So, autoimmune disease is a huge portion of my practice. I actually have autoimmune patients coming to me from 4 different states, if not more. I also treat hormone abnormalities, which can be a whole discussion. However,
That's a separate podcast, probably.
that probably is a separate
It's very
podcast,
important,
but that the whole area of hormonal balance is completely misunderstood, and that goes back, several years and a lot of different discussion, and it's an interesting discussion.
Well, let me ask you this: do you think that hasn't? Almost all, if not all, of our hormones are cholesterol-based molecules. So, do you think the war on cholesterol had anything to do with the crazy outcomes with hormonal issues, as low testosterone, changes, and all of those things, as we've gone through this 30 years now of dietary change?
Absolutely. And so you need, what is the precursor? The precursor of all of our hormones is cholesterol. Turns into pregnenolone, and then goes to progesterone, goes to DHEA, and filters all the way out through the system. You need a certain level of cholesterol to make all of your sex steroid hormones. And so as you drive cholesterol levels too low, you also, by default, are going to decrease the levels of your natural hormones in your body. Mm-hmm. And what are the side effects of low testosterone? Well, one of them's vascular disease. Mm-hmm.
Yeah.
Duh.
Duh.
And it goes on and on. And so
You don't want that.
yeah, so
and male erectile problems. Duh.
You
exactly.
don't want those either.
Yeah.
Exactly. So, and in neurology, it's also been shown that, published in the Journal of Neurology, in the elderly, as your cholesterol declines, your memory declines.
Yeah. Tell me what the Bredesen protocol is, since you mentioned that.
The Bredesen protocol, Dale Bredesen is out of UCLA. Bredesen has been researching Alzheimer's for like 30 years, and the stuff that he has found is incredible. we had an advanced practice module on cognitive decline and reversing dementia. And one of the first speakers was like a 60-year-old female who had the ApoE double mutation. ApoE is one of the genes for dementia. She had developed full-blown dementia, almost. Her husband was an airline pilot. She started studying these things before. She had changed her diet. She had taken the right supplements. She had regained all of her memory. She was walking down the street with her husband, the pilot, the airline pilot, saying, "You remember him?" He says, "Dang, I don't remember him." But his protocol is based on, what he thinks of as the way he pictures is dementia is like the Georgia Dome with 36 big holes in it. And Aricept and Namenda plug 2 holes. But there's 34 other ones that are not, that are left open and the rain's coming in. Right. And so they address this with multiple modalities. One of them is diet. All of these people go on a ketogenic diet with intermittent fasting. And there's lots of supplements. There's nutritional repletion for zinc. Zinc is a huge one with memory loss. And there's a lot of other different ones. So, he has his book is The End of Alzheimer's. It's an amazing book. I am not a Bredesen protocol practitioner. I don't have the time to do everything. I love the protocol, but we can't do everything. But there is a mnemonic for it, which is pure. But basically, you have to try to decrease your exposure first off, because our body can eliminate a certain amount of stuff, and there's a lot of, many of us also have single nucleotide peptide defects, gene defects that impair some of our ability to detoxify, which is one. 2 is if you keep taking them, autistic kids, that's one of their big issues is their brother who doesn't have the gene SNP can eliminate mercury, but they've got a gene SNP that they can't eliminate it. So the same amount of mercury builds up in this one. So the principles of detoxification are first, eliminate the toxins, or eliminate toxin exposure. Organic foods, decrease exposures to pesticides, herbicides. Don't walk under a plane that has leaded gas. All planes have leaded gas because that's what helped get them off the front. So unfortunately, we can't do that.
Yeah.
So we have to. We can't get rid of some of these exposures, but eliminate exposures as much as we can. Drink plenty of good water, not city water, which is chlorine and fluorine and all of the things in it that helps poison our systems.
Now, fluorine's supposed to be good for me, right?
Wrong-o.
All right. What's going on there? I think it seems bad.
Tons of stuff against that. That's that's not a good thing. It really is not.
Even our toothpaste has fluoride in it.
Absolutely,
right?
It's a toxin.
Yeah. What is it toxic for? Too.
Well, it fights cavities.
There's tons of different things, but if you look at the elemental table in the halides, there's chloride, fluoride, all the ides, okay? But fluoride really is not, many countries, and there's a push in many cities to get it out of it is a toxin that comes out of waste plants, and they pay governments to put it in the water to make us think that it's good for our teeth. It's really not. So fluoride is a toxin. It also, iodine, what's iodine do? Thyroid, it competes for iodide in the thyroid. So there's issues with fluoride.
So it's not the same chemical that was originally supposed to be put in the water, correct? I mean,
it's a toxin that comes out of factories, and the American Dental Association would probably not want me to talking about all this, but I disagree with a lot of their stuff. It's much more of an issue than at the surface. But anyway, and then so going on into the detoxification. So you do infrared saunas, and there are a lot of detoxifying foods. And IFM actually has a detoxification diet. Broccoli is one of the most detoxifying things that we can eat. And as you and
That's
so
pretty good, then. Broccoli's good.
Broccoli's good.
It's actually sprouted broccoli, right? So wouldn't sulforaphane be the best in the youngest part?
Actually, any broccoli, but if you want to get the full amount in full doses, you can eat 15 pounds of broccoli a day, or take a dim product.
15
You're gonna need
pounds.
to juice.
Bit hard to do that, but
That's a lot of broccoli.
That's a lot of broccoli.
Robert Roundtree, one of the best guys in
need a
toxicology, will tell us his lecture. He says broccoli.
So obviously we're big fermenters here at Pretoria Fields Collective. Fermentation,
chicken wing
it's a good
eaters.
thing or a bad thing for the gut? Where different fermented foods are better or worse?
We're hoping you say yes.
You're hoping you say yes.
Donna Gates, one of the biggest. Donna Gates went through A4M when I did. Donna Gates is a doctor who was very sick. Turned out she had a lot of yeast issues, and one of the biggest things she promotes is fermented foods. So
There we go. Yes.
Yes, we win.
And beverages.
Organic.
All right.
next, that's into the dysbiosis, gut organisms, and toxins. And so I'm thinking, does this guy have any mercury amalgams? Is he an overtrainer where he has intestinal permeability or leaky gut? I'm thinking, does he have micronutrient deficiencies because he's on the standard American diet, which he says he's on a good diet, but do we really have some of these deficiency processes going on? There's the causes are just way out there, as you can understand, but it's a lot more than cholesterol.
Oh yeah. So, and good point. So you're talking about a CrossFitter who suddenly has, who hasn't smoked. Well, he's a stressed out professional who doesn't get hardly any sleep and works 18 hours a day.
Stress dissolves your immune system. Your stress stress dissolves your intestine. Okay, so stress in and of itself creates intestinal permeability.
How about 35 years of just that grind, and then, although he's exercising, he's also not is he eating the standard American diet, but he's eating out a lot because he's constantly in towns that aren't here, so he's not eating at home. Totally nailed it.
I've only been stressed for 16. My oldest kid's 16 years old.
Yeah.
So I've been stressed for 16 years. Yeah. So
my
gut.
You got that going for you.
What about
So
sleep?
I'm really worried right now.
What about sleep in this guy? Does he sleep?
Yeah, like 6 hours a night.
Okay.
Sometimes less.
Stanford University, sleep 5 hours or less, 25-pound weight gain, but there's also tons of cortisol issues, neurotransmitter issues that comes out of lack of sleep. So chronic lack of sleep. One of the guys that was talking in March last year at a conference we went to says, if you don't sleep 8 hours tonight, it's 43 days later, your body's going to catch up to that one night of decreased sleep. Remember, I spoke at the two founders of American Academy of Anti-Aging Medicine, top 10 things. Sleep's one of the most important. Sleep's probably, but sleep deprivation is probably contributing to this guy's problem.
This guy's a CrossFitter. He's got to wake up at like
3.
4 to get to the gym.
All right,
CrossFit
now,
before work.
Jim Laval, I quote this guy every day. This guy knows more about physiology than anybody in the country, hands down.
I like your excitement right now.
Yeah, well, thank you. But Jim's been treating athletes all of his career. He had the Laval Metabolic Clinic. He knows really more than, hands down. What Jim tells me on a regular basis is that the highest growing abnormal metabolic abnormalities, cortisol abnormalities in the country is CrossFitters.
Wow.
I love
Because it's
CrossFitters,
an abnormal.
by the way.
You may like it. I like the concept, but
Yeah, I just-
metabolically and all of the things that happen in the stress system, it's actually and Jim treats professional athletes. He treats from all across the board, and he said the highest growing area of the metabolic cortisol abnormalities are in the CrossFitters.
See, that's interesting.
So is that because they're overtraining, or is it because they're injuring themselves chronically? Is it a similar idea as the long distance runner who's getting chronic leaky gut?
No, it's a different concept. It's a different process. So the long distance runners are really, those are gut issues. The overtraining syndrome or the crossfitting syndrome is more of the cortisol, testosterone, all in this HPA axis. HPA, HPT, HPG. HPA is hypothalamic, pituitary, adrenal, thyroid, gonadal dysfunction. It's a lot of interesting stuff. And the interesting thing is, what are they doing, you say? Getting up at 4 o'clock in the morning?
Yeah, they got to get in
Sleep
before work.
deprivation.
Yeah.
Sleep deprivation
You gotta go work out
is
before
a
you
setup for, all of your HPA dysfunction.
So yeah, I figure they've decided that the chemical that causes the increase in the gap junctions is zonulin. I think they've named it. And so, of course, every drug company in the world is now working on a zonulin inhibitor. And as soon as we have one, every gastroenterologist in the world is suddenly going to understand that leaky gut's the most important problem we faced in the 21st century. So I'll tell you another thing. So my patient, said that he thought that the gluten thing was BS. So do you think that obviously we go back to spectrum of disease. Is there a safe dose of gluten that humans can eat? I mean, is it, or does all of it cause a problem? Is it genetically, does it depend on what your ancestors were doing? What do we do with it? Because there's certainly a ton of it. It's pretty much in everything.
Okay, so with respect to that, gluten, there's 5 different domains. Gluten is like a 290 amino acid entity. And it's got 5 major domains on it. 2 of those domains are absolutely not digestible by any human. Alessio Fasano, who I just referred to, who's now at Harvard, has stated that no human can digest totally gluten. Other people have taken that statement and went out and said that nobody in the world should eat gluten. Dr. Fasano addressed this at the June 2018 annual International IFM conference and said people have extravasated what I said about this to that. And he said, I didn't mean that. Many people can tolerate gluten. They cannot all digest it. It is not a problem for everybody. But there's no question that non-celiac gluten sensitivity, there's 40 papers published on that now to every 1 paper published on celiac disease. And it is absolutely, if you have an autoimmune disease, it is absolutely one of the first things we do to eliminate gluten from the diet, because with intestinal permeability, that's going to go through, and we know that there are sites on the thyroid that recognize that as enemy. So in a short, yes, and that's a short. There's a lot more explanation, but kind of chunked down. That's some of autoimmune disease, gluten, and only 50% of those people probably are sensitive. But you eliminate everybody, and then you reintroduce it at some point in time and see how they're doing.
So to break this down and make it easy, what is there an anti-inflammatory diet that's fairly simple? I mean, it seems like it would not include gluten. Would it include gluten? I don't think so.
Look, we've done a lot of gluten-free stuff. lately.
We do. Yeah. Seems like gluten.
I'm
might
scared
be,
of gluten.
Seems like gluten might be bad.
I'm scared to hell out
So,
of it.
So actually-
autoimmune diet. What does that even mean? I guess would be
There
the-
are a lot of different, quote, autoimmune diets. So there's the autoimmune paleo diet. That is pretty good in and of itself. But we know that there are 10 top things in our diet that produce an inflammatory or an autoimmune response. Those can be, some of the top 5 are wheat, dairy, soy, wheat, dairy, soy, peanuts, and corn. Those are the top 5. We actually have
wheat, dairy, soy, peanuts, and corn.
Correct. Those are the top 5.
And
That's
they
a lot
all
of
have a
stuff.
common protein antigen, or is it different mechanisms, or
Pretty much the protein. So it's the protein that stimulates the immune system. It's not a carbohydrate that comes through there. It is a protein with a certain amino acid sequence that leaks through the intestinal wall and stimulates the monitoring cells on the side. It is usually a protein sequence. So there are certain, and that kind of goes along with what we're talking about the athlete. There's a protein sequence in that endothelium or that endotoxin that they're recognizing. So there's these what we call toll-like receptors on the cells that recognize certain enemies. And so mostly it's certain sequences of proteins.
So is this all inflammatory disease we can expect to see a benefit with if we contribute to this diet? I mean, what are the things that this would be good for, I guess, is the way to ask that.
Pretty much all inflammatory disease. What we got 4 big categories that we're talking about when you talk about the spectrum where I think about it is allergy, inflammation, autoimmune, cancer. That's the whole spectrum of autoimmune disease. So, what are the big triggers of that? The big triggers of that are going to be foods, bugs, toxins, trauma. So someone may have input from trauma, which different mechanisms. But as a rule, food intervention is one of the first things that we recommend.
Yeah. So we've talked about a lot of things that we shouldn't eat. Are there some foods that we definitely need to? Broccoli.
15 pounds a day.
Sulforaphane. If we can get enough sulforaphane, we actually will live forever.
So pretty much I think what is the Paleo-Mediterranean diet in simplification is fruits, nuts, seeds, lean sources of proteins. In other words, and pretty much what we can grow, what we can pick, unprocessed foods, animal foods that are grass fed, what you'd go out and shoot or catch.
What he eats in the wild,
what we said before. Always low in a lot of people, but there are multiple. If you look at NHANES data, it's magnesium, zinc. Very interesting. You just made me think of a slide. If you look at the incidence of zinc deficiency over the last 20 years, 50 years, incidence of zinc deficiency has been going up like that. Incidence of cancer has been going up like that. Zinc is an essential cofactor in DNA repair that we do at night. So, there are. You listen to Mark Houston stuff. Why do we have cholesterol abnormalities? One of the top 3 micronutrient deficiencies. So, yes, micronutrient deficiencies abound. Do I think everybody needs to be tested? I think that there are certain basic things that we should supplement with, and then based on the clinical situation, we may consider doing other nutrient tests. And I do some pretty extensive nutrient testing.
That's exactly why we put all of our beer in 100% zinc cans.
Zinc free
That's a
cancer.
total.
Is that right?
That's a total lie.
He might have had one too many Sholeys. So I'm pretty sure, Nikki, the next question is yours.
Well, what do you think is the number one vitamin deficiency that you see here?
Well, I mean, worldwide, and this is a worldwide thing, is vitamin D deficiency. I mean, vitamin D deficiency has been attributed to, if, Dr. Cannell of the Vitamin D Council quotes that if we would replete everybody with vitamin D, 30% of chronic illness would go away. That's a bit high. However, University of California, San Diego, several years ago put out a paper, vitamin D deficiency is at the core of most cancers. University of California, of Denver, Colorado, University of Colorado, Denver, 3 or 4 years ago, vitamin D deficiency is at the basis of prostate cancer. But the other deficiencies, the highest ones are zinc, B6, magnesium in my mind.
Neat.
And this is pretty cool. This is a real quick case report. Had a lady came to me last year who had a periorbital dermatitis that was horrible. I mean, she was red, inflamed, all here. Dermatology could see her, nothing happened. They gave her all their creams, all their doodahs. She came to me. I gave her a cream which was B6 based with some lithium. It blew it up worse. So I scratched my head and says, Dr. Dan, what would you do? I put her on 300 milligrams of pyridoxal 5-phosphate, which is vitamin B6. 6 weeks later, complete resolution of that rash.
So she was just B6 deficient.
It was a B6 issue
A tough one to treat.
Yeah.
that nobody could treat.
So, actually, what I thought Nikki was going to ask you was about bioidentical hormones. Because I'm pretty sure she wrote this question.
Well,
Because it wouldn't have been a question that I wrote.
So, what's the difference in your bioidentical hormones and your pharmaceutical typical hormones?
Why did we wait to the end of this?
Because we didn't want it to last very long.
No,
No,
we
no,
should-
we saved the best for
We
last.
should ask that very first.
Humans evolved.
It was a dark and
Starting
story
from the
night.
beginning.
Humans evolved with a very intricate system that worked pretty damn good. Okay? And God made hormones and put them in, and they worked pretty good for about 2 million years. Maybe up to 2 billion. I don't know. So, synthetic hormones, just like many things, go onto the cells. Our body did not create mechanisms to break them down. So the most important thing about anything you put into your body and any hormone that's naturally there, hormones are supposed to go, pop on the cell, do what they do. Your body breaks them down and gets rid of them. Okay? And so our body did not develop a mechanism to detoxify or break down 17-medroxyprogesterone. What the hell is that?
Isn't it from like horse urine?
That's the synthetic progestin. No, that's synthetic progestin. The different things go onto horse urine. Horse urine is Premarin. The other thing about Premarin is that Premarin breaks when you detoxify estrogen.
It's gone to a different level. We just talked about horse urine.
That's what I thought.
You asked
so
for it.
when you break down, and this, I've got a whole slide deck actually on
Next
this
thing you'll be
question
talking
right
about
here.
non-breast milk.
But synthetic hormones are broken down into either estrone, estradiol, estrone. Then you go down other pathways and you take them down to the 2-methoxy, 2-hydroxy, and so on and so forth. See, we're getting into kind of complicated. All of your synthetics break down into estrone, which is the most potent, and that's the one that's most prone to cause breast cancer. So synthetic hormones go down the wrong, speaking of detoxification, go down the wrong detoxification pathways, where the natural hormones go down the more gentler pathways that we developed through millions of years of evolution. And so that's why, in a nutshell, bioidentical hormones are much safer in my mind than using synthetic hormones. And, you know, and the other big concept here is, which most people don't get, is that hormones need to be in balance. And hormonal imbalance is where we get all of the different female symptoms that starts coming on in the perimenopausal phase.
They're no fun.
And that's the reason. That's
a reason for the question.
That's a reason for Paxil, Zoloft, and all of these other agents in people that do not understand hormonal imbalance.
There's also a genetic predisposition to have a lot of these symptoms. Correct? Talking about breast cancer, we're talking about, you know.
Oh, for breast cancer, yes, but
BRCA positive and
what is BRCA? What percentage of breast cancer is due to BRCA?
Yeah.
5%. So as I tell patients on a regular basis, your biggest risk factor for having breast cancer is to have a negative family history, because 90% of newly diagnosed breast cancers do not have a family history.
Are 90%?
90%. Only 5 to 10% of patients with breast cancer have a BRCA gene that's contributing.
Do you think that's possible, that there's not been a lot of research on the fact that, you know, there was not earlier testing on prior generations?
No. I think...
Wow, you just dismissed that pretty quickly. I mean, we weren't BRCA testing prior than, I don't know, how many years ago?
What was the incidence of breast cancer 30 years ago? Incidence of breast cancer was 1 in 20 to 1 in 30. What's the incidence of breast cancer today? The incidence of breast cancer today is 1 in 7. Genes do not change that fast. Breast cancer is due to environment.
Wow,
breast cancer is not significantly. Estrogen is related to breast cancer, but breast cancer is a multifactorial process.
All right. Well, if you go back and you backtrack a lot of those breast cancer incidents to prior generations, and you look at the possibility of genes affecting that, do you not see some type of... I don't think there's been enough research to correlate what you're saying to just, 90%, that's,
You don't need genes to get a family history. And I certainly understand some of what you're saying, but there's a lot of, like, what is it? There's a lot of testing out there that's available. One of them is color, and the color, it's just color.com or whatever. The BRCA used to be like a $2,500 test. FDA or whoever just cut them off and said,
it's
all right,
still expensive.
Actually, $200 gets you about 20 or 30 genes to look at your breast cancer
Not
genes.
with my insurance plan.
No, you can buy this for cash. It's color.com or one of those, and you actually have a genetic counselor that's available to you on this. They've looked at a lot more genes that are looking for breast cancer risk. But if you look at the whole picture, BRCA turns out, if you have BRCA is a highly penetrated gene, and there's interestingly a lot of things that you can do about BRCA. If you got BRCA, you want to look at your estrogen metabolism, see how you're going down those estrogen metabolism pathways, because we can affect those. We can change those. This is work done out of University of Nebraska over the last 40 years. But there are some other tests out there, and BRCA now used to cost $2,500. You can get it at a $200 panel online with genetic counseling for breast cancer risk.
Wow.
Fair enough.
All right. Well, thank you for being on tonight. I think we could do another 4 or 5 podcasts just on any of the limbs of those trees that you
And
described,
roots.
and the roots. So here's to No Damn's Given podcast. Thank you, Dr. John Abell.
Thanks.
Thank
sir.
you.